जो एंगल चेक कर लो तो बराबर दिख रहा है। सब कवर हो रहा है।
खड़ी रखे थोड़ी साइड में थोड़ा सा दिखेगा स्लाइड्स से थोड़ा आगे आए स्लाइड आने के बाद पता चलेगा।
ये तो छोटा स्क्रीन है, इसको जूम करेंगे तो दिखेगा बाद में। स्क्रीन लाइट की वजह से फेस ब्लैक थोड़ा सा दिखेगा। हाँ
Hello, good afternoon everyone. I hope everyone is settled after the lunch so that we can proceed with the program. So first of all, I would like to welcome our guest speaker, Dr. NAIR and Dr. RICHA BANSAL from Apollo Cancer Center. And to proceed with our program, we will have our first Dhanvantri Puja, which is our tradition of KDA. So we will proceed with the Dhanvantri Puja. For that, I will invite Dr. Shalini Gore.
Good afternoon, everyone. So every program of KDA starts with the Dhanvantri Puja. So here I would like to call Dr. Pathak sir and Dr. Dimasha ma'am. I also call Dr. Himani ma'am.
अरे आओ, अरे आजा, अरे आओ, आओ।
नमामि धन्वन्तरिमादिदेवं सुरासुरती वन्दितपादपद्मं लोके जरारुकभयमृत्युनाशनं दातारमीशं विविधौषधीनां शङ्खं चक्रं जलौकां ददतं मृतघटं चारुदौर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्यां शुकपरिविदधत् मौलिमम्भोजनेत्रं कालाम्भोदोज्ज्वलाङ्गं कटितटविलसत् चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदवन् प्रौढदावाग्निलीलम्
I start with the KDA prayer. Om Sarve Sukhinah Sarve Santu Niramaya Sarve Bhadrani Pashyantu Ma Kashyaptu Bhavaye. Om Shanti Shanti Shanti. Om Astu Ma Sarvaya Tamsoma Jyotirgamaya Mrityorma Mritam Gamaya. Om Shanti Shanti Shanti. Thank you, ma'am. Thank you, sir. After this, I would like to call Dr. Mithila for the proceedings.
Hello everyone. I would now like to invite Dr. Nita Nair. She is a lead breast surgeon, senior consultant, and oncoplastic surgeon at Apollo Cancer Center. Dr. Nair has completed her training in Mumbai and has been a consultant at Tata Memorial Center for 15 years. She is a well-renowned leader on breast oncology and has trained numerous surgeons in her breast career as a teacher. She has published over 100 articles and chapters on breast cancer care and delivered over 200 talks nationally and internationally. Her areas of interest focus on oncoplastic breast surgery and improving cosmesis and quality of life for women with breast cancer. Dr. Nita Nair. May I call Dr. Himani ma'am? Felicitate. Thank you, sir. Because of the lights. So then आप इस तरफ आ जाइए. Because the projector का light will come.
The face will not. And that's the
वीडियो के बारे में आ रहा है?
मैम इधर आ जाओ बिल्कुल
इस तरफ आ जाओ.
प्रोजेक्टर से
ये आपका बैनर बीच में आ रहा है. Thank you, sir.
So Kharghar is home for us. I mean, ACTREC is down the road. It's been home for years. And like I was telling Madam earlier, half my family lives in Kharghar. So I'm trying to keep this very basic in not just what happens for us as breast surgeons is y'all are the first stop for most women. Women look at it as कुछ तो गांठ हुई है, कुछ हुआ है, लेडी डॉक्टर के पास जाना है, which is always the gynecologist. And you're our first step. We need you to be able to tell patients what is right, what is wrong. More than the GP, I know that they trust their gynacs more than they do. I trust my gynac. So I believe that we have to be able to work together. The way we look at breast lumps and breast cancer, the first thing everybody thinks of is pain hona chahiye, गांठ में कुछ problem honi chahiye. We have to have a certain concern. I think that's where we come in trying to be able to tell our patients it's always a painless lump at the start. And that's why they need to come in and see you. And I believe that what the brain knows or the mind knows, the eye will see. Cancer is not just something that's affecting elder women. You always see a lot of young women, and we always think that that's probably a fibroadenoma. That's not going to be cancer. Unfortunately, in India, the age for cancer is a median age, which means that most women who present with cancer are in their 40s. Not like what we see in the West, which is where they're much older. So, of course, we have women who come with axillary lumps, breast lumps, nipple discharge. We don't want them coming in with late stages, which is where they start having puckering of skin, lymphedema, and definitely not with stages of advanced disease. So which is where we need to work together as a community to bring them in early, because that's our step towards cure. Breast cancer, when detected early, is almost curable. In terms of that, we talk about survival at 95% 5-year survival. That means out of 100 women, 95 of them will survive 5 years without disease, without any problem, when detected early. We always say that the best cancers to have, if you have to have cancer, is early breast cancer or thyroid cancer, because that's what you're going to do well with. So we need our women coming in early, and that's where you all come in. Why these numbers are important is, if you see, the West is 1 in 8 women. The concern with the West is, one, they do a lot of population-based screening with mammography. They pick up a lot of DCIS, which probably does not need to be identified. DCIS being pre-invasive disease. So that's something that we don't always have to treat if it's indolent, if they're not going to present with it in their lifetime. But doing multiple scans very early in life tends to have that number going up. What's happening in India, unfortunately, is that 1 in 22 versus 1 in 64. Why that's important? 1 in 64 is a fairly baseline number, which is a good number to have. It means that most of your women don't really come with cancer in the breast. Why is that changing in urban India? Is because of urbanization and the way we're changing our lifestyles. Our girls are having children later. Most of them don't breastfeed for the entire year because they go back to work earlier. Obesity is a concern in the country. It is increasing. All of these are risk factors for breast cancer. So with us catching up with the West with urbanization, we're unfortunately catching up with the West with numbers of cancer. So this is some of the work that we had done through the Tata Memorial Hospital when I was with them, is we just looked at what kind of patients present in India. And this is data from across the country. 65% patients present with operable cancers, but unfortunately, we still see 35% women presenting with advanced disease because most women feel this is not going to happen to me. It's just a lump. It's not paining. It's nothing, and leave it alone. We need to, for every time a woman comes to you for some sort of a checkup, awareness is the key. You make her aware of the fact that not every lump is cancer, but if detected early, it can be treated easily. That's where we move forward towards making our country as good as the West in terms of treatments. What's the unfortunate concern now is that in India, for every 2 women that are diagnosed, 1 lady dies of it. And that's because of the fact that it is all advanced disease. Like I said to you, if you present early, we are able to cure cancer with the breast. Unfortunately, we're still seeing 35% women presenting in later stages of stage 3 and 4, and we are struggling with that. So what are we able to tell our patients? Because breast cancer is not something we can prevent. We know risk factors. Like I'm sure when Richa will talk to you, you will talk about cervical cancer and a vaccine that's available for it. For breast cancer, you can't prevent it, but you can pick it up early. That's the benefit that we have. So we look at what are risk factors. Some things we can control. Some things we can't. We can't control the fact that we're women and we have a higher risk than the men in the room. They do have a risk. 1% of breast cancers come in the men. So it's not like males don't present with breast cancer. But as the female gender, we are at higher risk. The older we get, we are at higher risk. What can we prevent, of course, is the use of hormone replacement therapy. So your women who go into menopause, when we give them hormone replacement therapy, there is a slightly increased risk. When women have been on oral contraceptives from a very early age for a long time, which is usually about 15 to 20 years, there is a slightly higher risk. But what's definitely a high risk is having your first child late, not breastfeeding the child, and obesity. And this, I think, is where y'all come in for sure. A very, very small percentage of breast cancers, and that's about under 10%, are related to genetics. So if they talk to you about having had a family member, a mother, an aunt, a sister, a grandmother, who has had breast or ovarian cancer, that should strike a bulb. We need to talk to them more about awareness. We need to make them more clear about what's required next. If you see women who would we send every woman and go get your genetics tested, understand whether your risk is high or not, that unfortunately just creates a lot of anxiety without an understanding of what we're looking at. Because again, like with most other cancers, we know very little about hereditary cancers, and we're still in very nascent stages and learning about it. What we do know is that if they do harbor a gene, most commonly the BRCA1 and 2 mutation, we know that their risk is almost 80% of developing breast cancer and almost 60% of developing ovarian cancer. And we want to be able to then treat them differently and identify disease early in them. So for women with high risk, like family history or genetic mutations, I think I'm going to choose to not use this, but it may just be the YouTube which may struggle with that. That's the only problem. So if you look at women who are high risk, that may be genetics, that may be family history, you're going to want to hunt for cancer. Then you do MRIs, then you do screening, which is more intensive. When you look at the general population, which is the average population that we treat or we see or we talk to, we're discussing routine screening in an average risk population. So we have 3 methods which allow us to screen for breast cancer. The first of which is self-breast examination, clinical breast examination, and mammography. Mammography currently is what is synonymous. You talk to anyone about screening, the first thing they think of is getting a mammogram done, because that's synonymous. We know that in women over the age of 50, definite benefit to do it once in 2 years. So that's what you want to recommend. Are there other alternatives? There are other options which I would say are adjuncts. You want to add this into your screening protocols. Talk to your women about self-breast examination. Self-breast examination empowers a woman. It gives you charge of your own health. So if you tell a woman, examine yourself every month, where if you're having your periods, 7th day of your period. If you don't have your periods, pick a date, 1st, 10th, whatever works for you, and examine yourself every month. It empowers the woman to understand that she can come to you if something comes up early. That unfortunately has its own pitfall. It's like with any other test. It's like with any recommendation a doctor gives you when nothing is wrong with you. You do it for a couple of weeks, a couple of months, and then we all stop doing it. All of us get told by our physicians, exercise, have a walk, avoid certain foods, eat healthy, diet. We all do it for the first 3 weeks or month after our physician has told us all this. And then we all move back. I'm sure with every patient that you all talk to about health, in terms of, keeping everything clean, talking about perineal health, all that happens for the first 2-3 months. They come back to you after 1 year, and you're rediscussing the same things with them, and you're reiterating the same things with them, because most women stop being compliant. That's the problem with self-breast examination. But if we are able to reiterate it, every time a woman comes to our clinic, we ask her, do you examine yourself every month? Do you evaluate your own breast? It brings the concept of awareness. You talk to them about breast cancer. You tell them that this is necessary for you to do, and this allows you to come to me earlier if you pick up a lump. Of course, there is mammography, which is a standard screening evaluation for women over the age of 50. There is a reduction. That means that you pick up lesions earlier. Because you will pick up lesions earlier, they will die of disease less. But it has a small pitfall, which is that you could pick up some lesions, some things which maybe did not need to be detected, like pre-invasive disease or DCIS. DCIS has multiple types. It could be very aggressive, where they present with a lump, it's high grade, or it could be indolent, low grade. World over, we are moving towards, if you pick up low grade DCIS, maybe keep it under observation and don't treat it. Till those studies come out, for the last 15 years, since mammography has become standard of care to now, and till those studies come out, we are offering all women with low-grade DCIS surgery, hormone therapy, and radiation if we do breast-conserving surgery for them. This is a lot of overdiagnosis and unnecessary anxiety for these women. And mammography has one of the biggest pitfalls. It depends on what your breast looks like. So I explain this to women very often, is what a mammogram does is it x-rays our breast. It depends on whether you have a category A or a category D breast for us to be able to identify disease early. A category D breast is an extremely dense breast. And the minute they have an extremely dense breast, it can mask a lot of small lesions, because parenchyma is white, as is the lesion. Fat is black. So it's not just about age. We know that with younger age, you'll see more parenchyma. Their breast is still glandular. It's not just fat. As they age, the glandular element goes down, the fat increases. It's easier for us to identify lesions. These are photographs a friend of mine helped me take. And if you can see, this is actually in one of the corners of Kharghar itself, because we were standing at a bus stop when we did this. We were all fellows at the time. Same spot that we stood for 4 days, and we took different photographs depending on how the sky was. That's a category D breast. Crowded clouds, you can't see anything. As the clouds keep reducing, you start seeing the moon come up. That's what a mammogram has a fallacy of. If it's a very dense breast, it will mask a small lesion. And if it masks a small lesion, if I have a patient who's done a mammogram, she's done a screening mammogram, we report it as normal, saying that there's no abnormality seen. If I don't insist that she also does a self-breast examination, she's going to do nothing for 2 years till her next mammogram. And this small lesion may then come up and she'll miss it. So teaching her to do a self-breast examination every time you talk to her is, even if mammogram misses these small things, by the time that lesion is ready to present clinically, she will identify it as a change in her breast. The other, so which is why currently the guidelines do suggest a mammogram, but for women over the age of 50 to 74, once in 2 years. And between the ages of 40 to 50, we do advise a lot of discussion with the oncologist before you go ahead and do it, just for the fact that it can do exactly that. It will mask a lot of small lesions. It gives us false sense of safety. And then women ignore changes in the breast, which is what we need to be able to educate them about. One of the other things is a clinical breast examination, which means they come to their gynecologist, they come to their breast surgeons, and they get examined. So we talk to them saying that if a mammogram is painful, or if you cannot get access to a mammogram, or you don't want to do a mammogram every year also, you can choose to do a clinical breast examination with your physician once a year or once in 2 years. And again, the benefit from the studies shows you that it's primarily in women over the age of 50. These are words I'm just going to talk to you about because it's all over. I'm sure you had a million people come to you from pharma, talk to you about doing an ultrasound, the handheld ultrasound, a thermoscan, and of course the use of MRI. These tools today are used in addition to mammography and not without it. They aid mammography in finding additional lesions because of the first problem that we discussed, which is mammograms can be dense. They cannot be our first line defense for our patients. What happens when our patients do come in with a lump? So the triple test is basically our, I'd say, gospel sort of absolute truth. Without a triple test, if you have your patient having an evaluation with a surgeon, please question the surgeon. It has to have a clinical examination, it has to have adequate imaging, which is mapping of disease, and then a good biopsy. Mammograms are a mainstay when we are doing surgery because you need to pick up non-palpable disease to be able to offer the right surgery. What we are able to feel on the hand, what an ultrasound picks up, often is much larger disease. You want to be able to pick up non-palpable, smaller disease before offering a patient breast-conserving surgery. So you make sure that the risk is not high of recurrence. Breast-conserving surgery is safe when it is oncologically feasible, which requires a mammogram and or an MRI in some situations. Most of us today advocate a breast-conserving surgery for our patients because it is honestly not just good for the patient in terms of cosmesis and quality of life. There is also data to tell us it is better than mastectomy for early breast cancers. The old data told us that there was no difference in recurrence, whether you did breast-conserving surgery plus radiation or a mastectomy. The newer data actually tells us that it is better when women have early breast cancer because we add radiation when we do breast-conserving surgery for early breast cancer, which does not happen if she had had a mastectomy. So which is why if your patient is young, you want to be able to make sure that she has recurrence much later and push it beyond. You want to be able to try and offer her breast-conserving surgery in the situation. Unfortunately, despite everything that we have, breast cancer does not get treated by one modality. You could present with early breast cancer or you could present with late breast cancer. We are going to use multiple modalities to treat it. If you ever hear anybody talk about oral cancers, they'll tell you that it's either surgery or radiation if it's early. The way breast cancer works is we use multiple modalities together because we don't base it just on stage. The three main receptors of ER, PR, and HER2 decide a lot of chemotherapy and options for us. Grade, stage, tumor size, lymph node, age, all of these also add to the various treatments that we discuss with our patients, which is why it's always a team effort. You'll find that your patient has gone to not just the surgeon, but also talk to the medical oncologist in the same day, also talk to a physician or a nursing supervisor, because we are moving towards doing care together. And the option is, and you hear of so many patients, we have this in the clinic all the time. One patient will tell me, I didn't get any medication after my surgery. the patient I was sitting next to for follow-up is on a medication. Why did you forget to give it to me? Then you remind them of the 3 receptors, saying that it depends on the type of disease. So breast cancer, though it sounds like it's one cancer, it's one organ, we have honestly moved forward in a lot of ways of how we treat it, based on the receptors, based on the stage, based on the age. Many patients will get chemotherapy first to bring down the size of the tumor, not just to offer breast conserving surgery, but also because after surgery, if there is no complete response, that means chemotherapy has not made the disease disappear, we may be able to add more drugs after that, which help in reducing some recurrence. So all of this is basically standard, and I'm sure you've heard this about 100 times with every person who talks about breast cancer. So let me talk to you about what's new. And the first thing, which I'm sure many of you read in the newspaper, was a study that came out of Tata Hospital. I was lucky to be been part of it. It's about use of local anesthesia at the time of surgery. So what we are doing now, and this, we just published this paper last month, what we're doing now is we're adding, with general anesthesia that patients get, we add local anesthesia while we're operating, and that's shown a small benefit. So with all the drugs that we have, we add small interventions like this to make a difference for our patients. So talk to your patients about this. Make your